So today's topic is the role of maintenance therapy in today's myeloma. We chose this topic because it's a highly requested one. Maintenance therapy remains standard for most myeloma patients in today's treatment landscape. So we want to know a little bit more about this therapy. And we look forward to hear from Dr. Rubenstein, who is an expert in the matter. So I'll turn the time over to him right after I introduce him to you. So he's an assistant professor and a malignant hematologist at the University of North Carolina and an associate member of the Lineberger, I think,
That's right. Yeah.
Comprehensive Cancer Center. His primary clinical and research area of interest is plasma cell dyscrasias, I think, and he's focused on clinical trials designed to improve the standard of care of patients with these disorders. In addition to clinical trials, he has an informatics background, wow, which he has leveraged to develop multiple prognostic scoring tools that are useful in the management of patients. So I'll turn the time over to him and I'll stop sharing now. Welcome.
Okay. Let me start my share and get booted up here. So thanks again for the invitation to speak. I always like talking to the HealthTree group. Today we're going to talk about the role of maintenance therapy after stem cell transplant. I gave a similar talk presentation to all of you a couple of years ago, and it's actually a rather opportune time for an update. So these are my disclosures. I've done advisory and consulting with a few of these organizations. Some of them manufacture things I'm going to talk about today. I am always tough but fair, or at least try to be. Yeah, sorry, I added another one. All right, so overview management of multiple myeloma. So multiple myeloma is the second most common blood cancer in the United States, with about 30,000 patients newly diagnosed per year. Many of you will know multiple myeloma is a cancer that we've made a lot of progress in treating in recent years. So it's very treatable in the vast majority of cases. However, it's not a cancer that we have a lot of good luck curing. And there's been some interesting work on how patients define cure, which ultimately our goal with all of this is to help patients. So the patient's definitions of what a cure means to them is very important. And most folks think of a cure as I can be cancer-free, not suffering due to cancer, and off treatment. So that is a state that maybe some very, very rarely patients can achieve, usually for relatively short periods of time. But generally, the part of that that's the most difficult in myeloma is getting patients off of treatment. So getting the best outcomes out of treating a patient for multiple myeloma generally requires continuous therapy, and that's where maintenance comes in. So this is an overview of the general pathogenesis of myeloma, or that's doctor speak for how myeloma comes to be. So normally what happens is when you either get sick or stimulate your immune system, for example, by getting a vaccine, that causes a type of white blood cell called a plasma cell to do what it's supposed to do, which is expand in its population and generate antibodies. Antibodies are these Y-shaped proteins over here. Most of the human antibodies are IgG, and they actually do look like a Y. So this is the normal physiology of how a plasma cell works, and how it's ought to work. And in myeloma, what happens is this population of plasma cells grows too much, becomes too enlarged, and takes over too much of the bone marrow such that the bone marrow can't work, and in some cases can invade into the surrounding bone and cause bony tumors, which is a very common manifestation of multiple myeloma. So the initial course of therapy for multiple myeloma is divided into phases. It's a marathon, not a sprint. The first phase of treating multiple myeloma is called induction. Induction is usually a more intense but brief course of treatment involving multiple drugs given simultaneously, the goal of induction being to achieve a state called remission. Remission, again, is a term you'll hear used a lot that different folks define differently. But generally, what remission means is cancer is not causing any suffering, and we can't identify active cancer anywhere. So there are different tiers of remission in myeloma that many of you may be familiar with, but the goal of induction is generally to get some kind of remission. For eligible patients, many patients decide to proceed with an autologous stem cell transplantation. That has nuanced risk and benefits that merit their own separate presentation. I've been privileged to give you guys a presentation about that modality in the past. But after transplant, because it's a malignancy, multiple myeloma is a cancer or disease that we can treat, but usually not cure, we generally have to offer some kind of maintenance therapy after a stem cell transplant to get the best imaginable outcome. Usually, maintenance therapy is lower intensity than induction, so it's either fewer drugs or lower doses of the same drugs, or potentially both. And in general, at this point in time, we are usually recommending continuing maintenance therapy until patients relapse. There are a lot of people trying to either develop strategies where we can stop therapy before, earlier than indefinitely. There are studies that are ongoing that some of you may actually be participating in that are looking at more defined interval maintenance durations. But currently, the usual recommendation is to continue it as long as it's working and as long as the patient's tolerating it. And then maintenance is usually continued until relapse, at which case we will have to come up with a new induction regimen to get the disease back into remission. So we'll talk a little bit about stem cell transplant. As I mentioned, I've given a dedicated discussion of this outside of this presentation, but if we're going to talk about maintenance, we probably have to talk about transplant, which is the thing that comes immediately before maintenance. So stem cell transplantation is what we call a consolidation therapy, the goal of which is deepening and prolonging remission. So as seen in the prior schematic, to get to transplant, you need to receive induction and achieve some sort of remission. So transplant is really a treatment modality that's used to deepen and strengthen one's position in remission. So there's many different types of transplant, and people may be more familiar with the allogeneic stem cell transplant because of bone marrow donor drives and things of that nature. So an allogeneic transplant is a transplant where the donated stem cells come from another person. That is not the kind of transplant that we do in myeloma. In myeloma, we do a type of transplant called an autologous stem cell transplant. Autologous basically is medical speak for from the patient's own body. So in an autologous transplant, a patient's stem cells are harvested using medication usually, and then they're stored to be given back to the patient to rescue the bone marrow from the effects of very high-dose chemotherapy. So the cells, very importantly, are not the primary treatment in autologous transplant. The primary treatment is the chemotherapy that's given before the cells, okay? So there's been many studies that have shown that what transplant in myeloma does is it prolongs the first remission. So here are two very similar curves from two prospective clinical studies comparing stem cell transplant-based approaches to non-transplant-based approaches in newly diagnosed myeloma. These are the most recent high-quality studies we have, but they are slightly not applicable to most modern patients because the regimen that's widest used is RVD, or Revlimid, Velcade, and Dex. This presentation keeps skipping forward. Many patients will get 4 drugs now, which is these 4 drugs plus daratumumab. And so what each of these schematics is showing is that patients who undergo transplant take a longer time to progress. So in order to explain some of these concepts, I am going to have to show some clinical trial data. I'm going to try and explain what these graphs mean now so that the future ones and these ones will make a little bit more sense. So these are graphs that show the percentage of study patients who have not had an event over a period of time. So at the start of the graph, it's 100% or probability 1.0. And as time goes on and more patients have some event, the curves will go down and eventually approach zero. You will see these curves with all kinds of different endpoints on the y-axis. The endpoint that's being shown here is progression-free survival, which is time from initiation of treatment to either myeloma progressing, so coming back, or to death. And each of these ticks that you'll see are patients who followed to that point, and then they either dropped out of the study or that is the latest follow-up point that we have available on those patients. So that's what all of these hash marks are, okay? So what you're seeing here is that the transplantation arm has, at every time point, essentially a higher percentage of patients that have yet to progress. So in both of these studies, this one being the IFM 2009 study from France, this one being the determination trial from the US, there are some slight differences, but both of these show the same thing, which is that patients getting transplant take a longer time to have their myeloma progress. However, the goal of therapy is not necessarily delaying progression. You guys care most in general about living longer and living better. And in terms of that metric, there are some open questions as to whether transplant helps us meet those goals. So these are overall survival curves from the same study, so different endpoint. This is simply time to, this is simply the percentage of patients who are still alive at various study points. Now, the vast majority of patients are alive, even on the determination trial here, at 7 years out. But we don't see significant differences between those that get a transplant and those that don't. Very similar proportions of both groups of patients are alive long-term on both of these studies, contrasted with the meaningful differences in how long patients take to progress. So transplant is useful for delaying progression. We don't know if it's useful for helping patients live longer or live better necessarily. So very important to talk through these data with the doctor and decide what your goals are to decide whether transplant is the right approach for you. We do have to mention transplant because maintenance as a concept was developed in the post-transplant setting. And generally, when we talk about maintenance in myeloma, we're talking about patients that have had a transplant. So as I mentioned before, the maintenance approaches that we use are generally deployed as long as a patient's disease remains in remission and they are tolerating the treatment. And I'm seeing some excellent questions in the chat. Please keep them coming. In my experience, this goes better if we collect to the end and then we answer as many of them as possible during the question session. So if I'm not addressing your question, it's not ignored. There's a pin in it for later. Okay, so definition of maintenance therapy. So we've been over this. So maintenance refers to a lower intensity treatment that is given to sustain remission achieved with higher intensity induction and consolidation therapies. So in myeloma patients, what this means is after getting a 3 to 4 drug regimen, after getting maybe a stem cell transplant, we back off on the intensity of therapy to keep disease in remission and hopefully help people live longer and live better. So why do we do this? So because multiple myeloma is not usually cured, achieving the best outcomes often requires continuous treatment. Combining multiple drugs, so giving more than just one drug, is often difficult. As many of you guys are pointing out in the chat, chemotherapy has toxicity, and the more drugs we give, the more side effects we encounter. You don't need to be an oncologist to know that. It's kind of obvious. Additionally, getting multiple drugs often places demands on all of your time because not all of our useful drugs, in fact, most of our useful drugs, with the exception of things like Revlimid, are given in an infusion center. And anytime you need to set foot in an infusion center to get anything, there goes half a day of your precious time. So that is a real factor in my consideration or non-consideration of multi-agent maintenance approaches. And then, of course, nothing in the good old US of A healthcare system is free, certainly not including cancer medicines. So multiple drugs incurs more risk of financial toxicity for all of you and additionally incurs risk of toxicity for the system. All right, so you can't have a presentation about maintenance in myeloma without talking about lenalidomide or Revlimid. So lenalidomide is by far the widest used drug for post-transplant maintenance. It is oral, so it meets the need of avoiding the infusion center. And the other thing that's nice about Revlimid is it forms a component of the induction regimen. So most patients that get to transplant are used to Revlimid, and it's at least familiar to them. The other critical point is that there are a lot of maintenance studies that have been done in myeloma. To date, the only drug that has been shown to result in patients living longer after a stem cell transplant is Revlimid. There are other drugs that may be reasonable to use for other reasons. There are certainly arguments that are evidence-based that can be used to discuss and support using other strategies in other settings. But no other drug besides Revlimid has been shown to result in patients living longer, which for most patients is the most important goal. So this is the kind of landmark iconic trial that established the role of maintenance Revlimid. This is CALGB 100104. Rolls off the tongue real nicely and very easy to remember. But this was a very large randomized trial of 460 patients that was conducted and read out in 2012. So it's about a 15-year-old study at this point. It's a pretty tried and true practice in myeloma. And so the investigators here, which CALGB is a cooperative group, meaning it's a bunch of academic centers that work together to do a trial that answers an important question that would not be feasible to conduct either through a pharmaceutical company alone or would not be feasible to conduct at a single center or a smaller group of centers. So most myeloma docs are involved in designing and conducting studies through this cooperative group mechanism. Usually the most important studies come from these cooperative groups. And so here you see graphs that'll be familiar. So patients taking Revlimid, which on this trial, Revlimid was given at a starting dose of 10 milligrams. And it was given with no break, so 28 out of 28 days. And it was given indefinitely, meaning not for 1 year, not for 2 years. It was given until it stopped working. And so that approach dramatically reduced the chances that patients progressed who were taking Revlimid. So here you see the progression-free survival curve, and you'll see that the patients that are taking Revlimid are much less likely to have progressed at all of the relevant time points. Unlike with transplant, we also see the same effect with overall survival. So not only are patients taking longer to progress, they are also less likely to die at the various time points following initiation of maintenance therapy here. The Revlimid graph remains on the top and meaningfully on the top. This is something called the p-value, which basically tells us the probability we would see this result by chance if Revlimid were not superior, and that probability is 3%, which is pretty low. There are many other studies that have been done with maintenance Revlimid. This is the one that has shown an overall survival advantage. And we generally follow this paradigm that was done on this trial, which is Revlimid initially with no break indefinitely, because it's the one that's been shown to make patients live longer. There are, as I mentioned, other trials that have been done answering the same question. Some of those trials were conducted in other healthcare systems and were smaller than the CALGB study and or deployed some different strategies and were not in and of themselves sufficiently powered, which is a term you'll hear statisticians and academic oncologists use, which basically means, was the study big enough to show what you think it ought to show? So this French and Spanish study were not big enough to show patients living longer, we think. And so investigators led by the leader of the CALGB group, which is Phil McCarthy. He's at Roswell Park in upstate New York. They combined the results of all these studies and showed that when you combine all the results, you get a really big benefit in how long patients get remission. So the duration of remission is roughly doubled if you go on Revlimid compared to not going on Revlimid, which is a very large benefit. And then when we look at overall survival, it takes longer to get to the endpoint. These curves track along one another until you get about 4 years out. And then eventually the patients getting Revlimid in the pooled analysis of the 3 trials also live longer. They live longer by about 25%, which is what this figure showed. So only drug that when it's been subject to these rigorous analyses shows us that it helps patients with multiple myeloma live longer. I don't need to tell any of you, and I'm seeing in the chat that even though it's great to live longer, that is an investment that is made with the price being paid of side effects. So the most common side effects we see with Revlimid maintenance, and many of you may experience other side effects. These are just the most common. Fatigue has many potential causes in most patients with myeloma, but by far the most common thing reported in studies and the most common thing I see in my patients getting maintenance Revlimid is fatigue. It can get better if we reduce the dose or stop the drug, but because it has a lot of other potential things that can cause it, we have to do a lot of work to ensure that it isn't something else making us fatigue before we cut back on the dose of a drug that has been shown in good studies to help us live longer. As people are talking about in the chat, Revlimid is designed to be targeted to myeloma cells, but it also has off-target effects on other cells that are similar to myeloma cells. The most similar cells to myeloma are the normal cells in the bone marrow. So the cells that produce and become red cells, white cells, and platelets, they don't always work normally in patients on Revlimid, and we can see them being generated at a lower number. So you can have lower amounts of red cells, white cells, and platelets due to the Revlimid. And in the long run, this increases our risk of infection. And then the other common side effect that we encounter is diarrhea, which is a very common side effect of a lot of chemotherapy drugs. With Revlimid, it actually very specifically impairs our GI tract's ability to reabsorb bile acids, which are chemicals our gut makes to help us digest fat. So you can't reabsorb them if you're on Revlimid. They kind of irritate the GI tract and overstimulate it and create diarrhea. All these are that side effect is very manageable. In the vast majority of cases, we can find a way to help reduce the frequency of diarrhea. Rare side effects that we see that are potentially devastating are blood clots. So all patients getting Revlimid need to be on some kind of medicine to protect them from blood clots. Can't be as simple as baby aspirin, but you need to be on something. And then in prospective studies, patients getting Revlimid compared to those that have placebo have a small, depending on the study, 2 to 3% chance of getting a secondary cancer. So another cancer can develop that we think may have been caused by Revlimid. There are a range of different cancers that are reported in the literature. Many of them are skin cancers that are relatively easy to treat, but sometimes we see things like acute leukemia and other bone marrow diseases that can be more difficult to treat. This is a devastating side effect when it happens, of course, but the important thing to know is that happens to the patients on these studies. And despite this risk, patients taking Revlimid are living longer. So it is a risk that we usually recommend that people take. The other thing I'll say is it's not my first rodeo, and I've taken care of enough patients that I've unfortunately seen a few develop these. It is usually happening in patients that make it a really long time. So patients that are alive a long time after their transplant are generally those getting these second cancers. Open question whether folks would have made it that long in a lot of cases if they hadn't used Revlimid. So not an easy pill to swallow, but a risk that we think in general it is worth taking. And this is a little more data on those secondary cancers. So the ones that we worry about the most are highlighted here: acute lymphoblastic leukemia, acute myeloid leukemia. These are data derived from the McCarthy study that I showed curves from, showing that 6 out of 230 patients, so a little under 3%, got those diseases. None in the placebo arm. In total, 8 patients had blood cancer, 1 in the placebo arm, so right at 3%. And then in the determination study, which is one of the transplant versus no transplant studies I showed curves from earlier, we actually see a balance in more of a balance in blood cancers. So there is some risk of developing acute lymphoblastic leukemia, which is a more rare form of blood cancer than myeloma, whether you get a transplant or not. So this shows that it's not only the transplant promoting second cancer risk, it's also the Revlimid. All right, so proteasome inhibitors, other drugs that you guys may be familiar with. This is another class of drugs that's widely used in treating multiple myeloma. There are 3 proteasome inhibitors currently approved by the FDA. Those are bortezomib or Velcade, ixazomib or Ninlero, and carfilzomib or Kyprolis. There are studies supporting the use of these drugs in the maintenance setting. None of them has been shown to result in patients living longer, unlike Revlimid, but they all have other fringe benefits in certain scenarios in which we might think about using them. And I'm going to go through some of those. So single agent Velcade, so getting Velcade subcutaneously on its own. What are the data supporting this practice? So the only data supporting this practice comes from a European trial that's quite old, published in 2012, called HOVON 65. And that study compared 2 strategies. Notably, the only Velcade maintenance was not the only difference. So some patients got a Velcade-based induction and Velcade maintenance, and then other patients got an outdated induction regimen. There may be somebody. Every now and then, I get a patient referred to me who lived for a really long time with an old strategy, and probably once a year I see somebody that got this VAD regimen, which is a very intense one of those chemotherapy regimens that we'd have to admit people to the hospital to get. Patients got that, and then they got thalidomide, which is like Revlimid beta version, basically. Long and sordid story about thalidomide that is very interesting. I don't really have time to get into, but point is, Velcade maintenance versus thalidomide maintenance is not the only difference here. And the results hint at a benefit in certain groups of patients that have forms of myeloma that we think are high risk. So these are the overall results from the HOVON 65 study. They showed not a meaningful benefit to getting PAD. Confusingly, the P stands for Velcade here. That's because Velcade is a proteasome inhibitor. So even though Velcade starts with a V, the VAD is not the Velcade-based regimen. We make things easy. Definitely. We're good at making things easy to understand. These curves are basically right on top of each other, so no benefit in terms of living longer for the whole study population getting the Velcade-based treatment. However, if you look under the hood, there are significant differences between the strategies in patients that have these high-risk abnormalities. So these blue curves, which are in all of these cases the high-risk populations, they do worse than the red curves, because lower percentages of patients are alive at various time points for these 3 high-risk subgroups of myeloma. So folks that have deletion 13, folks that have a 414 translocation, folks that have a 17p deletion. So all of these are abnormalities with the chromosomes, which are essentially the hardware to DNA's software. Very common to have a chromosome abnormality in myeloma. Probably most patients with myeloma have chromosome abnormalities in their myeloma. Some of them are associated with reduced survival, these 3 being some of them. And we see that the proteasome inhibitor may help those groups of patients. But again, caveat is that it helps compared to a strategy that doesn't involve Revlimid that we don't now deploy. So whether Velcade in the maintenance setting does anything for those folks, for like folks treated now, a lot less certain. Ixazomib maintenance, or Ninlaro, was an idea that was very appealing to a lot of folks because unlike Velcade, which has to be given in an infusion center, Ixazomib is oral, so it can be taken at home, satisfying one of the critical needs of maintenance therapy. And it works the same way in myeloma cells, more or less, as Velcade. So an unfortunate theme is that generally, it doesn't look like Ixazomib is as effective as Velcade. Trials with identical designs, except that one trial uses Velcade and another uses Ixazomib, the Ixazomib does not perform as well. So in a prospective study comparing Ixazomib to placebo, not like the prior study comparing Velcade to thalidomide, itself an active drug, Ixazomib only prolonged progression by a period of less than 6 months. That's compared with placebo. To put that into perspective, the benefit in delaying progression of Revlimid is 30 months, 5 times. So definitely not as useful of a drug. Here is that progression-free survival benefit shown on a graph. You do see patients taking longer to progress getting Ixazomib than getting placebo, but you'll notice that the percentage difference is meaningfully different. This is about a 28% reduction in the chances that folks progress, whereas with Revlimid, as you may recall, was greater than 50%. More attractive to a lot of people than the single agent proteasome inhibitors are using proteasome inhibitors and Revlimid together. So there's 2 regimens comparing proteasome inhibitors with doublets, so both proteasome inhibitor and Revlimid with Revlimid alone. This is a hard, I shouldn't say it's a hard pill to swallow, it's like a hard shot to take, because kind of the point of maintenance is to avoid the infusion center. So I don't love the idea of using 2 drugs, one of which tethers a patient to the infusion center in general. However, in patients that run a higher risk of myeloma progressing, because the myeloma disease biology is indicative of a higher chance of progression, I will think about doing this. And I do this in many of my patients with higher risk disease. This is a single arm study that was led by Ajay Nuka at Emory, who's a friend and colleague. And so this is a study in which they took patients with high risk types of myeloma and they gave them 2 drugs, Velcade and Revlimid, together. And what they found is very good in a single arm results in terms of the probability that patients with certain high risk subtypes of myeloma were progression free and lived. So on the left, you see the PFS and OS, or progression-free survival and overall survival, for all the patients. On the right, you see patients with deletion 17p, which is a high-risk chromosome abnormality. These curves are essentially superimposable, meaning that they don't look different for patients with high-risk disease. So this suggests that adding the proteasome inhibitor to the Revlimid may result in outcomes similar to the outcomes that patients with standard risk disease would have. Again, it'd be better if there were an actual comparison to Revlimid alone, but these results are suggestive enough that I think it's reasonable to do both drugs in somebody with high-risk disease. Better data come regarding the strategy of giving carfilzomib or Kyprolis along with Revlimid. So there have been 2 big studies, forward-looking studies comparing 2 drug maintenance to 1 drug maintenance. This is called the Forte trial, which is a 3-arm trial that was done in Italy. So they randomized patients to receive carfilzomib and Revlimid or Revlimid alone. And I'll point down here to this graph on the right, which is called a forest plot. And it shows the benefit of treatments in different subgroups. What we see here is that folks with high-risk cytogenetics and folks with higher stage disease perform very similarly. The benefit is very similar in patients with high risk and standard risk groups. These bars here are pretty close to each other. There's not a big difference between them, which suggests that adding Kyprolis to Revlimid is as beneficial in folks with high risk disease as it is in folks with standard risk disease, which is encouraging. And then here's another study called Atlas, which was mostly done in other European countries, which essentially shows the same thing. Again, I don't love the idea of giving 2 drugs in maintenance to everybody. The other thing I'll say is that if the endpoint being measured here is time to progression, it's not true that adding Kyprolis to Revlimid in the maintenance setting has been shown to result in patients living longer. I really need to see that before giving a drug routinely to patients in maintenance. When a patient is not suffering from as directly from their cancer, I have a much higher bar to make that patient sicker by giving them chemotherapy. So I really like to see overall survival advantages in the maintenance setting before I change my own practice as a philosophy. But folks with high-risk disease, where the risk of myeloma progressing is higher even than in a patient with standard risk disease, I think about it and I do it a lot of the time. Yeah, those are just some boxes highlighting it. So Dara, obviously a drug a lot of y'all will be familiar with. That's a great drug that is a monoclonal antibody to CD38. So it's a targeted therapy to myeloma. It is very easy to give. It does require going to the infusion center, but eventually only once a month. So very appealing idea to look at Dara in the maintenance setting. Unfortunately, studies of single agent daratumumab in the maintenance setting show a very marginal benefit, meaning there's a very slight advantage to continuing Dara after transplant. The last time I gave this talk, the data suggested no benefit. Now, the biggest study of single agent Dara maintenance is showing a tiny advantage, which could well be a statistical fluke based on the time that we've looked. And I'll show you what I mean by that shortly. I personally have a lot more enthusiasm for the dual maintenance strategy with Dara. Dara has always been a drug that plays better with others than it plays on its own. So I am looking forward to ongoing studies that are looking at daratumumab and Revlimid in combination. I think it will likely perform better in that setting. So these are the latest data from the biggest dedicated study of daratumumab maintenance. This is a study called Cassiopeia. This is a slide that will be presented at the EHA meeting next month. And it shows that, so basically the way this study was designed is it had 2 randomizations. One was to get Dara-based induction or a non-Dara-based induction. Then patients went to transplant. Then there was a second randomization to get Dara maintenance or placebo. And so the biggest difference is between these 3 groups who get any Dara at all and this group that got no Dara. So the no Dara option here, not getting Dara either pre or post, is clearly inferior. However, the patients who get Dara prior to transplant and Dara after, they are shown to have a very modest reduction in their probability of progressing. So this p-value I was talking about before has to be under 0.05 for us to think it's significant. And this number is 0.048. So it's barely under that threshold. Furthermore, this ratio, which shows you what the probability is in total of progression, is not very low, meaning that the overall chances that somebody getting Dara progresses are not that different than somebody getting placebo after maintenance. It's only a 24% reduction. Again, contrast that with over the 50% reduction that we see with Revlimid alone. So I do not think that this study is convincing that we should be using Dara as a single agent in the maintenance setting, because it does not even dramatically delay progression. And it certainly has not been shown to prolong survival like Revlimid has. All right, so I'm nearing the end, so I'm just going to talk about a couple of studies that are ongoing. These are the studies I'm more excited about that are looking at combining daratumumab with Revlimid. Again, not to beat a dead horse, don't love the idea of putting folks in an infusion center in the maintenance setting, but Dara at least is only once a month. So an easier thing to recommend to somebody that should not be suffering from cancer for a very long time. So this is the Auriga study, which randomizes patients to get Dara and Revlimid or Revlimid alone. Patients get it for 36 cycles, so about 3 years. And then it's looking, in addition to overall survival, at the probability patients clear minimal residual disease. This is a similar study, which we have open at UNC. This is one of those cooperative group studies from the Southwestern Oncology Group, which is led by the MD Anderson folks, basically. Randomizes patients to get Revlimid or Revlimid and Dara for a shorter duration, only 2 years. And then the other neat thing about this study is it's attempting to answer the question of whether we're able to stop maintenance in patients that have very deep remissions, which is very appealing, would be very appealing to me if I were a patient, and is very appealing to the patients I take care of. So patients that get MRD negative on either arm are randomized to either continuing their therapy or stopping their therapy. So if those groups do equivalently, it may show that the modern regimens are good enough that we can stop in some patients. Here's all that summarized. So Revlimid has by far the most progression-free survival and overall survival advantages. It does have some potentially bothersome toxicities, but as we spoke about, they're either manageable or occur at very low rates, and it's given by mouth, in my opinion, making it the general best choice for maintenance. Other drugs are generally associated with lower benefits in terms of delaying progression and improving survival. Minimal residual disease, something you'll hear us discuss, and it's a hot topic now because the FDA has recently allowed us to use this as an endpoint in designing studies. So basically, minimal residual disease refers to a tiny amount of myeloma that we can find by a very sophisticated method that we can't see either with the naked eye or reviewing scans or a marrow biopsy just under the microscope. Long story short is good docs disagree on whether testing this is useful in making actual decisions. My opinion is it's more useful as a trial endpoint. I do check MRD for prognostic purposes, and it gives us another objective data point to track, but I don't hinge my own decision-making on MRD. Okay, so trials, I do trials. Most myeloma docs do trials. I think all patients with myeloma should be offered a trial at any fork in the road of their treatment. There's many important questions to answer in the maintenance setting. I mentioned, is adding Dara to Revlimid beneficial? What's the best approach for patients with high-risk disease? And then can we use minimal residual disease to determine who needs more maintenance and who needs less? And that's all the slides I have. I'm sorry I'm a little bit over, but I'll make myself available for questions. And if we don't get to you, feel free to send Marisol an email, and I'm happy to answer your aggregated questions in the coming days. All right, so I'll go through the chat first, if that's okay.
Yeah.
So we got a question about Revlimid and platelets not fully recovering. So this is an excellent question. It's exceedingly common. I think with bone marrow suppression in general, it's a risk-benefit assessment. So with platelets specifically, the chances of having a meaningful bleed, with a platelet count that's abnormal but above 100, like in the question, that risk of bleeding is pretty low. I routinely will continue Revlimid for mild thrombocytopenia like that's being asked about there. I would not change the dose for that. And I don't think it portends like a high risk of long-term problems with Revlimid. It's exceedingly common for patients to have those mild and manageable bone marrow suppression on Revlimid. It's not always a reason to stop. I think I addressed that question. But for that specific concern, I usually do not recommend making a change. All right, we got another question about transplant failing, which is an unfortunate circumstance when it happens. And the answer depends on what is meant by failing. So you're saying?
I'm sorry to interrupt you, but do you want me to read the questions out loud, or do you want to read them? Because people who will receive the recording won't be able to see the list. So they
Why
can.
don't you read? Why don't you read? That's better.
Yeah,
okay.
It says, my SCT failed. What are some reasons?
Good. So as I was saying, depends on what is meant by failing. Fail could mean that the stem cells don't engraft, which may mean that there was excessive bone marrow suppression by chemotherapy or by myeloma itself. prior to collecting the stem cells. That is usually the reason we don't get a successful engraftment. Unsuccessful engraftments are quite uncommon, which isn't to say that, what happened to this individual can't happen, but transplant failing to engraft is pretty uncommon. Transplant not benefiting patients is also uncommon, but is a little less uncommon. So there's some patients who get a transplant and the melphalan doesn't do anything to treat the myeloma. That generally means we need to go back to the drawing board and adopt a different treatment because it means the myeloma cells are not sensitive to the usual drugs and usual strategies that we use to control myeloma. When this happens to my patients, I consider a more radical change in therapeutic strategy. We definitely need folks such as this to participate in studies so that we can learn better how to treat future patients and, more importantly, get these patients early access to novel strategies like CAR T and bispecific antibodies. So I think that addresses the question. If there's another question, feel free to throw it in the chat and I'll get to it later.
Perfect. The next one. Why? Oh, yeah, go ahead.
You go ahead. No, you go ahead.
Why aren't donor cells used in transplants?
It's a good question. So it's such a good question. It had to be studied by a big clinical trial. The big clinical trial, many big clinical trials looked at allogeneic transplant, which is transplant using donor cells, versus either auto transplant, which is the transplant we do now, or other chemotherapy approaches. Those studies don't show that using a donated stem cell product results in better survival. So doing that doesn't make people live longer. It also does not appear to cure myeloma in the vast majority of cases. That type of transplant has higher probability of curing, for instance, acute leukemia, but myeloma does not appear to be likely to be cured by an allogeneic transplant. And furthermore, an allogeneic transplant has a lot of really bad potential side effects, side effects that are worth taking the risk of if there's a chance we cure. But basically, the transplant can result in the allogeneic transplant can result in the donated cells attacking normal and healthy cells, not just myeloma, and that can cause big problems. So need to see more benefit. There are very smart people working on optimizing that procedure. It may end up back in the landscape at some point, but for now, it's not. All right, next question.
It says, can data work well without other drugs for treatment or maintenance?
Yeah, good question. I think we addressed somewhat that question in the presentation. So the answer to any question starting with the word can is yes, but in most patients, it's not as effective to do DARA on its own in the maintenance setting as it is to use Revlimid on its own, and it's probably going to be less effective than DARA and Revlimid, which we're seeing trials looking at that question. DARA in general, great drug. It's better. I guess if there's any basketball fans here, it's like John Stockton. It's not like Karl Malone. It's really good at assisting other drugs and helping them work. It's not as good at slam dunking on its own. And the Cassiopeia results I showed earlier are consistent with that. All right.
We have one
next question
about Dara as well, so I'll just ask that one. It says, okay, so Dara is not so good alone, but if it's working when it stops, can you add Pomalyst and make it better?
Good question. Okay, so Pomalyst. So in general, if a patient is relapsing on a drug, like a patient getting DARA is relapsing while they're getting DARA, I don't think continuing DARA is usually that helpful. So if somebody's getting DARA on its own, and they're relapsing while getting DARA on its own, I feel better about changing the strategy more significantly. So stopping DARA and using something else in its place. If DARA is stopped for another reason, like a side effect or a patient deciding that it's not worth it for them anymore, and then a patient relapses after several months or years after that, then it's absolutely okay to reintroduce it, and it's very reasonable to combine it with a drug like Pomalyst.
Okay.
Pomalyst has no data in the maintenance setting. I do it in some very select cases. Patients that don't respond to a Revlimid-based regimen prior to transplant will often get a Pomalyst-based regimen. And for those patients, I'll use Pomalyst in maintenance, not Revlimid, but there's no high quality evidence supporting that strategy. That's just some informal practice that a lot of us have adopted. Doesn't make a lot of sense to use Revlimid after transplant if it didn't work beforehand. All these studies, that I showed showing Revlimid results in people living longer, you didn't get on those studies if Revlimid didn't work anymore. So,
Okay, perfect.
okay,
So,
good question.
yeah, I'll go back to Revlimid because we have a lot of questions about that. So it says Revlimid diarrhea has been hard to control. Those decreased to 5 milligrams still have diarrhea.
Yeah, so good question. I mentioned the mechanism of Revlimid diarrhea is that it impairs our body's ability to absorb bile acids. I usually recommend in cases of severe Revlimid diarrhea that we use a medicine that sequesters bile acid and binds it up. There are several medicines that work that way. Questran and Welchol are my two go-tos. They are a little annoying in that they can cause constipation and they have to be taken usually multiple times a day. But for severe Revlimid-related diarrhea, such as that which the patient is describing, I think the juice is usually worth the squeeze. And so I make quite liberal use of bile acid sequestrants for patients that struggle with Revlimid-related diarrhea.
Okay, perfect. It's
I just want to emphasize disclaimer. I'm sharing what my usual strategies are. I'm not issuing formal medical recommendation.
Yeah.
All of that is to say, I would discuss a bile acid sequestrant with your oncologist. Welchol, Questran, see what they think.
Yeah, perfect. We have an similar one about the doses, like what dosing regimen you usually recommend. Are there any differences in efficacy of the two regimens between taking Revlimid continuously?
Which question is this?
It's nearly at the bottom, like the third one from the last one to the first one. It says for Revlimid maintenance, what dosing regimen do you recommend?
Yes, that's a great question. I usually will start off with continuous Revlimid because that's what was studied on the CALGB 100-104 study. And that's the approach that's been shown to result in improved overall survival. There are other studies that had Revlimid 3 weeks on, 1 week off that probably would have showed the same thing if they'd been designed a little differently, basically. So I think that's a very reasonable approach. I don't start off that way, but if a patient struggles, with marrow suppression or diarrhea or fatigue, I have a pretty low threshold to go to 3 weeks on, 1 week off, even though there's not a formal study showing that as a survival advantage. I believe that if they designed the studies looking at 3 weeks on and 1 week off the same way they designed the CALGB study, we probably would see the same benefit. Basically, the 3 week on, 1 week off study, the biggest one was done in the UK, and the UK has a federalized health system which has benefits and disadvantages. One of the disadvantages is they sometimes mandate things happen on a shoestring budget, so they force the trial to stop following patients after 3 years. And so I don't think they looked far enough into the future to see the benefit. So I start with continuous dosing with a low threshold to back off if someone isn't tolerating it.
Okay. I'll go to the top of the list, so it's easier.
Actually, can you go to Carol T's question? That's a really good question.
Sure.
I want to clarify.
My husband was offered to join that double randomized trial of Rev plus Dara or Rev only after his stem cell transplant 3 years ago, but his primary oncologist said monthly Dara and Dex with the Revlimid was standard of care, so we decided not to go for the trial.
Yeah, I want to clarify. So, my opinion is that is not yet the standard of care, which isn't to say it's wrong to do it. There is not a study dedicated to the question of Dara Revlimid versus Revlimid that has presented results. There are big studies and important studies and good studies, the biggest of which is one called Perseus, which looked at a daratumumab-based 4-drug regimen, a transplant, Dara and Revlimid, So patients, one randomization, they got that or all that minus DARA. So it's looking at DARA pre and post-transplant together, not DARA pre, second randomization, DARA post. So that study shows huge benefit, and I have changed my practice because of that study and used DARA before transplant. I don't know that it's answered the question about coming to the infusion center every month after a transplant and whether that is worth it. This is a concept that myeloma doctors argue about. DARA and Revlimid certainly is an easy combination. In my opinion, I need to see a prospective trial showing meaningful benefit to using another drug in a dedicated capacity. I do not think the various arguments that are made about why that trial I mentioned, which is called Perseus, shows we should use DARA after transplant in addition to prior to transplant. Those arguments do not personally convince me. And I'm happy to explain that in some more depth offline. I just want to make sure I get to other questions.
Perfect, thanks. It says, how much lower is the risk of neuropathy if Velcade is administered sub versus IV?
Yeah, the easy question, great, good question, but an easy one. It's lower, way lower. I don't think anybody should get Velcade IV for any reason because of that specifically. Yeah, I mean, it goes down by a factor of something like 5.
Okay, perfect.
Yep.
Do you ever use triplet therapy for high-risk patients? DARA, Velcade, Revlimid.
Good question. My general high-risk maintenance strategy that I use is Velcade and Revlimid. Because the weight of the data showing that a proteasome inhibitor, in addition to Revlimid, benefits folks is greater than that for DARA and Revlimid, which I just spoke about. But I don't think any of us has a firm idea. And as you saw from the data I presented, it's not the biggest studies. Some of the studies are pretty old. So I think it's reasonable to do that. Again, more drugs, more side effects. In general, that's a patient population that, should be in remission and experiencing as few toxicities from chemotherapy as possible. I don't think it's unreasonable. It is not my own practice to give 3 drugs in the maintenance setting. I think we need more data before we're routinely doing that.
Perfect. I think you already talked about this one, but I'll just read it aloud. It says, I am on DAR and Pomalyst. Any comments? But I think you already talked about that.
Yeah, so that's a really good regimen for relapse myeloma. So folks that's myelomas come back, DARA and Pomalyst is a great combination. If it's being given not for relapse, there probably is also a really good reason, but I pretty widely use that regimen for folks that have had their first relapse. Not my only regimen that I use in that setting, but it's a good regimen.
Okay, perfect. What would treatment recommend if stem cell transplant and Rev and DARA patient relapsed?
Yeah, it's a good question, and I think there's many reasonable answers to that question. I I would put this patient on a clinical one of a number of clinical trials that we have at our center, looking at earlier immune therapy. But I think if we don't have access to such a trial, probably it seems like the best drug that patient hasn't gotten is Kyprolis. So I try to design or carfilzomib. So I'd give off trial, I'd give a carfilzomib based regimen. There's many reasonable ones. So yeah, general answer, difficult question with, I think that would be a question. There's many ways to skin that cat.
We have one about kidney disease, so I'll just go for that one. Did these studies you are quoting include patients with significant kidney disease?
Oh, really good question. The answer is no. Patients with very severe kidney diseases are not included in these studies. It's a huge gap in our evidence because myeloma causes kidney disease. It's very common for people to end up with bad kidney disease. We desperately need more data. There's retrospective data showing that Revlimid is a good drug in people with severe kidney disease. I did not present those data. I only presented like gold standard studies for the purposes of this talk. But we don't have the same level of confidence about Revlimid in folks with severe kidney disease. My confidence level is still pretty high, The thing is, you have to just be more careful dosing Revlimid. It's cleared by the kidney, so people with kidney disease can accumulate a lot of Revlimid and may have more side effects. All right, I think I have time for one more question, and then what I'll ask Marisol to do is collate the remainder I haven't answered. I will provide some answers to those later, and then if anybody else wants to send her a question by email, I will answer those as well.
Perfect.
So
Do you
be a
want
little time, but I will do it.
yeah, do you want to choose the question or just a random one?
Why don't you pick one?
Okay, perfect. It says, can you please explain what a partial remission may mean post stem cell transplant? My husband oncologist has told him that this is the case. My husband
Okay.
will start BRDs again soon, which is the same induction protocol that he has.
Okay. So partial remission is what that means is that there's been a 50% reduction in the amount of myeloma that somebody has or more. So it's between 50 and 90% specifically. So we've gone some of the way towards making the myeloma go away, but more than halfway, but not all the way. Importantly, some patients achieving partial response can do well for a really long time, even without intensifying their therapy. So it's not necessarily the case that that means we've failed. Depending on what exactly has happened to the myeloma burden over time, it may make sense to extend the induction a little bit longer. And I do sometimes do that. It may make sense to use consolidation, which it sounds like this patient is getting with additional chemotherapy after a stem cell transplant to try and make the remission deeper. I don't always do that, to be honest. So that's what partial remission means. What the implications are in terms of strategy, I think depends on some details.
Perfect. Well, thank you so much for your time. It was really interesting. I learned a lot today. Do you have any closing remarks before you leave?
No, I just want to close the same way I always close these presentations, which is that I know that patients' time is precious and that you guys go through a lot and we say jump and you guys ask us how high, and I'm always very humbled by patients investing their time in these endeavors. I hope this was helpful and informative to you, and I wish all of you all the best in your journeys with multiple myeloma.
Thank you so much. I'll send over the questions via email.
Perfect. Okay.
Thanks,
Hope
Howard.
everybody has a good rest of your afternoon.
Yeah, you too.
Bye-bye.
Bye-bye. For everyone else, I'll share my screen again real quick to talk about our next meeting that will happen in August. We have a topic, but we don't have a time yet, so I'll let you know as soon as we have one. And it will be how personalized is multiple myeloma treatment and how is that changing. So we have more events today. At 5:30 p.m. Eastern, we have our Spanish group meeting. If you have someone you know who speaks Spanish that can join us today, we'll have Dr. Gerald talking about multiple myeloma and answering questions. Then later today at 7 p.m. Central, we'll have the non-secretary group meeting, and we're talking about mental health. And on Saturday, we have our cure tour. On Saturday, June 8th, we have our cure tour in Columbus. We have our 5K, our annual 5K, and then we'll have a cure tour. Maybe you're seeing we have been having these meetings. We'll have a virtual soon so you can learn more about this, but we are pretty excited with these workshops we're doing about Cure Hub and what this may contribute to a cure for myeloma. And then on the 18th, we have the MRD group meeting. We don't have the topic yet, but I'll let you know as soon as I have it. Okay, so you'll find the link to register for these events and even more that we aren't mentioning yet. So at the bottom of the screen. And another thank you to our sponsors, Adaptive, AbbVie, Genentech, J&J, Pfizer, Regeneron, Sanofi, and thank you all for being part of this community. Hope you have a great rest of your day. Bye-bye. And yes, the recording will be sent out to everyone. I see the question on the chat. Happy Memorial Day to you too. Bye bye.